Good day, everybody. I'm just going to start. I'm hoping that everyone can hear me. So the panelists can hear me and Margie can hear me when we did a sound check. But if there's any issues with sound or video or visual, can you please let us know via the chat function? The meeting will be recorded and we're hoping to make this available on our website. And we'll keep questions until the end. Margie Hams, our education coordinator, will be monitoring the chat box. I would like to begin by acknowledging the traditional owners of the land on which we all meet today, paying my respects to elders past, present, and emerging through the many countries that Darling Downs and West Moreton region represents. On behalf of everyone present here today, we acknowledge the need to continue working towards reconciliation and the continuation of cultural, spiritual, and educational practices of Aboriginal and Torres Strait Islander peoples. Our webinar today is talking specifically to nurse-led age-appropriate child health assessments for children in care, but more generally for all our children that we see in general practice, and is aptly titled Making Every Contact Count. Today's webinar, unfortunately, we can't see our presenters today, but our webinar will be presented by Holly Kennedy. She's our nurse navigator at West Moreton Health and Hospital Service, focusing on pediatric disability and NDIS. She's committed to changing the life course trajectory with a background in development and behavioral pediatrics. Her vision is to support health service capacity and to champion early identification and early intervention for children with developmental needs. We also have Nicola Godfrey, who's the team leader for our Child Development Service at West Moreton. And Nicola is passionate about working with vulnerable children and families to achieve optimum developmental outcomes. We also have with us from West Moreton, Brooke Ridley. She's a child health nurse and is really passionate about supporting children and families to attain optimal health outcomes, which we all are passionate about in general practice as well. I will now hand over, I think Holly will be presenting, or they will be presenting together from the hospital. So I'll hand over to you, Holly. Holly will be sharing her screen as well.
Okay, thanks Tanisha for that introduction. So I'll just flick through some of those first slides, if I can get this to work. So good afternoon, everybody. Thank you so much for having us join you today. We're really excited to be able to present to you around this concept of making every contact count when we're looking at child development in the primary care setting. So just a quick overview of today. We're going to be talking a bit about some of those fundamentals of development in terms of brain development or early years brain development. We're going to be looking at a little bit at attachment theory and how that works in relation to child development. We're going to talk about the adverse childhood experiences study and some of the data and how that relates to child development. We're also going to be talking a bit about trauma-informed care and what we mean by early intervention. We will go into some of those red flags of child development and what to look out for, some of the developmental screening tools that are available to our primary care colleagues, and then we will lastly look at some of those key partnerships and gateways to some of the referrals that you might wish to make or pathways for child development. So making every contact count, we thought this was probably quite a good title for us today. And really, as clinicians working in the child development space, we are really quite acutely aware of the real crucial role that our colleagues, yourselves in that primary care space have as really the frontline clinicians when we're talking about child development. In that you will see the children day in, day out that potentially do need some early intervention and do need some issues to be looked at in terms of child development. So what we know about what we tend to know about families and children where there are issues around child development is that often these are the families that they're more likely to need intervention and services but equally they're less likely to actually access those services. So often these might be children who, for example, don't attend kindy or daycare because of the financial implications of that. They might not attend for those routine developmental checks. They may not be the families that actually utilise the drop-in universal services that we offer. And they may not attend for those follow-up appointments or the recommendations that are made for following up on developmental outcomes. So with regard to that, we recognise that we really need to look at this in terms of opportunistic encounters or opportunistic appointments that may occur, for example, when you're giving an immunisation, when you're doing a routine, for example, Indigenous health check, or just a routine GP or clinic nurse appointment, that we really make the most of those contacts, because essentially you might be the only person that actually sees that child from a health professional perspective. And certainly we often find that children might hit the school age and then all of a sudden there are these developmental concerns that nobody's ever been able to raise before. So really thinking about that opportunistic appointments and opportunistic encounters that we have. And those moments potentially, when we go through this, they could have life-changing developmental health and psychosocial life course trajectory changes for that child in the long term across multiple aspects of their development. So as we look through these different areas today, our hope is that we do support you to make the most of those contacts, that we support you to recognise the need for those opportunistic interventions in child development realms, and that we support you in building familiarity with some of the common issues which can lead to child development concerns. And hopefully we can support you in utilising and understanding the pathways for intervention across multiple domains such as health, social, therapeutic, disability and educational sectors. Just trying to change this slide. It's a bit slow today.
Holly, and while you're waiting, I think what you just spoke about is those invisible families. I'm hearing that word a lot recently, that actually they're invisible to education, everybody else, except when they go to their general practice, probably most often for an acute condition.
Yeah, that's right. And for us in the hospital, it's opportunities like if they turn up to ED. You know, it's really important that we do have a good look at these children, and that we do take the opportunity to actually observe, use some of our observational skills around what we're seeing in our consult rooms. And also take the opportunity to bring them back in for that follow-up as well. So once they've attended for perhaps one aspect of care, if we pick up concerns around child development, whilst we're formulating an opinion on what the best pathway is for that child, bringing those children back in to follow up on some of those areas of concern that we've identified. So I've just popped in here, just want to talk a little bit about the developing brain. So we know as human beings, we're born with around 25% of our brain already developed. So that's actually quite a small percentage compared to the rest of the sort of animal kingdom. Essentially what that means is by the time we are 3, our brains will have developed up to 80%. So we've got this rapid growth that happens in those very early years. And I've just put a picture up there on the top right-hand corner. So this is a colleague of mine that's made these brain babies. But you can see just on the left there, that's a newborn brain. And then in the middle there, that's a 3-year-old's brain. And that's a huge amount of growth that happens. And if you just compare that to the adolescent brain on the right there, yes, there is definitely growth that happens in those later childhood years, but it's the window of opportunity you can see is really quite visible in those early years. So really what I want to try and get across today around the brain is that our early experiences in life really determine our brain architecture. So just hold that word architecture in your mind. So brains are built and not born. So essentially what we mean by that is that in this explosive period of growth, the neural pathways, the synapses or connections, essentially the wiring of our brain is being built in response to our environment. So that is our experiences of caregivers, the stimulation that we have opportunity to experience, our learning opportunities and our sensory experiences. All of this in these very early years help us to develop some of those neural pathways and for those synapses and connections to happen. And that forms the basis of that architecture of the brain. If we're with that newborn brain there, so we're born with roughly, they think, around 10 trillion of those synaptic connections. By the time we're 3, that's increased by 20-fold to around 200 trillion. So that's a lot of work, a lot of learning, a lot of experience that needs to happen in those 3 years to really make the most of that opportunity of brain development. And I guess the other flip side to that is if we don't experience some of those core needs in child development, so that opportunity for learning, that warm, attentive caregiving, and those sensory experiences that we need in that early phase of life, then we can have the opposite effect where we don't actually have as many connections and neural pathways built. And actually what can happen is something called neural pruning, and that's where pathways that might have been developed, if they don't have the opportunity to really practice or really move forward in some of those skills, we can actually see that there is that neural pruning that happens of those pathways. I've just popped an image down there on the bottom right hand side, and you're probably really familiar with this already, but this came from the studies in the 90s of the Romanian children from the orphanages. And they, I'll just quickly go over that. So these were Romanian orphans who were essentially rescued from orphanages where they had suffered severe deprivation, sensory, emotional, and physical neglect. Studies followed some of the outcomes for these Romanian orphans, and they were adopted into European families and then followed throughout their lives. And you can see here, this is a really extreme example, but you've got the brain on the left there of a normal healthy developing 3-year-old. And on the right is a very extreme example of neglect and abuse, where the differences are very stark. And that's really where we're looking at brain architecture. So we know that poor social and emotional stimulus and caregiving can alter our neurochemical responses, but we also know that in stressful situations, if children that are exposed to very stressful situations for prolonged periods of time, whereas there is that release of stress hormones continually, what happens also is that the brain's limbic system, predominantly the amygdala, becomes hyper aroused. So that's the brain's fight or flight response center, and that plays a governing role in our emotional responses. When that is triggered over and over, that can also have an impact on a child's brain development. So we think about those children that are in out of home care and some of the experiences that they have had, and children living, for example, in households where there is domestic violence on a regular basis. Conversely to that, so you've got one area of brain that becomes quite hyper aroused, and we also know that for children that suffer severe adversity, the prefrontal cortex, or the smart executive part of the brain, this becomes less developed and has less synapses and connections, so the wiring is affected in that way as well. And this part of the brain is responsible for our planning, our reasoning, our decision making, our impulse control, so that fine-tuning executive functioning, and that's what we mean when we talk about executive functioning. And if you think about some of the children that we see that have problems with things like emotional regulation, inhibition of impulse, and behavioural issues, we do need to think about their early childhood experiences and the impact that has had on that developing brain. So just talking about the sort of building blocks for healthy child development, I just want to talk a little bit about secure attachment or attachment in general. So we know that healthy child development really depends on a child's relationships, and particularly their attachment to their primary caregiver. And I've just popped there a picture on the slide and a quote there from Donald Winnicott. There is no such thing as a baby. There is a baby and someone. In other words, we don't look at children in isolation. We look at them as part of their family, but predominantly we also look at them as part of a dyad, particularly with their primary caregiver, which quite often is the mother, but not always. So attachment was first talked about way back in the 1900s, and that was Winnicott, and he first recognised the importance of that relationship with the mother on a child's health and development. And then later work by John Bowlby and Mary Ainsworth in the 70s, that they went on to identify what a secure and healthy attachment looks like, and then from there what the concept of insecure attachment styles and the effect that that can have on a child's overall health and developmental outcomes. So we know children experience their world and their environment in terms of relationships, and that those relationships affect virtually all aspects of their development. We're talking about their intellectual, social, emotional, and their physical health and development outcomes and behavioural. So we know that warm, attentive, stimulating parenting and care is the foundation for this healthy development. And this is really seen through a word that is often used in terms of attachment, which is the word attunement. And that essentially is being aware of and responding, or a caregiver responding to a child's inner world. So their thoughts and their feelings and their emotions. And that there is a dance of attunement, or sometimes called a dance of reciprocity, where you've got this match between the parents and the infant's emotional connection. And that you can see that because that results in this mutual joy and this positive interaction and the sensation of pleasure and safety for the infant and indeed for that primary caregiver. So we can see these in our clinic settings, particularly as if we start to develop a relationship with a family over time, over multiple appointments, that we can start to get an understanding of just the quality of that attachment that's there. So when we're looking at attachment, fundamentally, it's the basic, in its most basic form, it's the human need of connection to another human being. And biologically, it's actually that means of survival. As the child experiences discomfort, so such as they're in pain, they're fear, they're cold, they're hungry, the assumption that that primary caregiver will be able to reduce that discomfort and that they will be able to meet that need helps the infant actually regulate their emotion and feel safe in their environment. So what happens then is that as that cycle happens, and it continues to happen, and it's very secure, this supports a child to really construct an internal working model of themselves and of their primary caregiver on the basis that they will respond to their needs over and over. And even when that cycle is disrupted for one reason or another, its re-establishment of attunement is also very important in terms of developing that secure attachment. So what is insecure attachment? So with insecure attachment, we know that that tends to be characterized by 3 styles of insecure attachment. We have ambivalent or anxious attachment, and that sometimes comes about when a parent might have been, or a primary caregiver may have been inconsistently responsive to a child's needs from an attachment perspective. So they may sometimes be emotionally available and emotionally and socially attuned to their child, and other times they are not. And so the child becomes either ambivalent about the fact that they will have their needs met, or actually becomes anxious that they don't feel that they can, for example, explore their environment because they're not sure that there will be that safe haven when they return, because they're not sure that the parent will be in that space by the time they come back to them. We also talk about avoidant, insecure avoidant attachment, and that's essentially where a caregiver has been consistently unresponsive. So the child learns that there is no secure base or safe haven, and so they learn not to seek this, and they tend to become withdrawn and struggle to connect emotionally. And so they don't look for it anymore. And so sometimes you can see that if a primary caregiver might leave the room, often these children are, there is no response to that. And when that parent returns to the room, there's not a huge response to that either. So sometimes that's able to be seen in the different settings that we see children in. I think worryingly, the third style of insecure attachment is what's called disorganized attachment. And essentially that's where it's this irresolvable paradox where the parent is both the source of the child's fear and the haven for the child's safety. So the child really doesn't know where they stand. And often it's seen when there has been a parenting style that's particularly frightening or particularly emotionally unreachable. And so what we do know about this style of attachment when we look at the research is that it's only a small proportion of children that have an insecure attachment that will have a disorganized attachment. But of those children, I think it's around 10%, of those children, psychopathology is very strongly associated in later life for these children, and very poor health and social outcomes for those children. So we know that insecure attachment is really linked to poorer physical and mental health conditions across the life course, and also physiological poorer health outcomes across the board. So Nicola's just going to talk a bit about the adverse childhood experiences. I'll just pop her on the headphones.
Hi everybody, it's Nicola here. So the ACE study is a really an acronym for the Adverse Childhood Experiences Study, which was a major epidemiological study that was conducted actually in 1995, was the original one, between the Kaiser Permanente, a huge insurance, medical insurance company in San Diego, and the Centers for Disease Control and Prevention, the CDC. So it's a retrospective and prospective analysis, very, very large study of 17,500 individuals. It was done in a primary care setting, and the population was actually middle class. So it's important to note that this was a middle class population and not really the high risk, lower socioeconomic population that we so often see in our work. The average age of the participant was 57, and it really was one of the largest investigations ever of childhood abuse and neglect and household challenges and later life, health and well-being. The ACEs refers to 3 specific kinds of adversity kids experience in the home environment: various forms of abuse, neglect and household dysfunction. In this study, it looks at 10 categories of ACEs and the effects of traumatic experience during the first 18 years of life on adolescent and adult mental health and psychiatric disease, chronic disease, sexual behaviour, healthcare costs, and life expectancy. So I've got them here listed for you. And so with the 10 categories, please note that okay, somebody might have experienced sexual abuse. It's one point for sexual abuse, whether or not somebody experienced sexual abuse once in their childhood or 100 times. So the types of abuse, you've got emotional abuse, recurrent threats, humiliation. So 11% of that cohort experienced it. Physical abuse, beating, we're not talking about hitting or spanking here. Sexual abuse is contact sexual abuse, more women than men, but overall 22%. Emotional neglect, 15%. Physical neglect, 10%. And in household dysfunction, it's split into the mother being treated violently, household member was chronically depressed, suicidal, mentally ill, or in psychiatric hospital. Now, when the reference to household member is not just parental, it could be a sibling, or it could be even an uncle that lives in the house with the child. Household member who was an alcoholic or drug user, parental separation or divorced, not kids that are raised by both biological parents, say in separate homes. It's actually if they're separated from a parent. And the household member, if a household member was imprisoned. So the ACE pyramid looks at the mechanism by which adverse childhood experiences influence health and well-being throughout the lifespan. It's really the conceptual framework for the ACE study, and the study has uncovered how ACEs are strongly related to the development of risk factors for disease and well-being throughout the life course. And obviously, the higher the score, the greater the exposure and much more increased risk of negative consequences. So if you look at the pyramid here, starting with the historical trauma, look at social conditions, local context, the ACEs, which affects disrupts neurodevelopment, can cause social, emotional, and cognitive impairment, adoption of health risk behaviour, disease, disability, social problems, and early death. Now, 4 or more ACEs, you'll see in this picture, if a child has experienced 4 or more ACEs, they're much more likely to have, over twice as likely to have cardiovascular disease. Anxiety, almost 4 times more likely. Teenage pregnancy, over 4 times more likely to occur. And to be a victim of violence, 7.5 times more likely to misuse substances at 5.6 times. Obesity, 1.3 times more likely. Respiratory disease, 3 times more likely. Diabetes, 1.5 times more likely. Cancer, 2.3 times more likely. And suicide attempts, 30 times more likely if they've experienced 4 or more ACEs. Higher ACE scores, individuals are more likely to be violent, have more marriages, more broken bones, more drug prescriptions, depression, suffer from autoimmune diseases, more work absences, and so on. So key findings from the ACE study, and also from dozens and dozens of other studies that have been using the original ACE data, they're really quite common. And even in this original cohort, the middle class population, 2/3 of the population actually reported having experienced 1 ACE, and nearly a quarter have experienced 3 or more. The powerful persistent correlation between the more ACEs experienced and the greater the chance of poor outcomes later in life, as I mentioned before, and the dramatic increase in what you see here. And I guess a key message too is the time factors in the study make it clear that time does not heal some of the adverse experiences. Just going to look at stress and the body's biological response to stress. So learning how to cope with adversity or stress, it's really a healthy part of child development. When we're threatened, our bodies prepare us to respond by increasing our heart rate, mildly elevating our stress hormone levels, such as cortisone, and tolerable, that's what we call positive stress. Tolerable stress is, and positive, sorry, would be something like, say, if you're going to sit an exam or going for a new, first day at a new job. Tolerable stress is serious temporary stress responses buffered by supportive relationships, and that could would be, say, if you've had someone's had a frightening injury or experienced the death of a loved one. If the activation is time limited and buffered by relationships with adults who help the child adapt, the brain and other organs recover from what might otherwise be really damaging effects. Moving on to the toxic stress response, where there is prolonged activation of stress response systems in the absence of protective relationships. Can occur when a child experiences strong, frequent and prolonged adversity, such as what I've just talked about with the ACEs. And it certainly can disrupt the development of brain architecture and other organ systems, and increases the risk for stress-related disease and cognitive impairment well into the adult years. Let's look at the analogy of, say you're on a bushwalk and you come across a snake. Well, you'll sort of have the fight and flight response will kick in, your heart rate will increase, the cortisone, adrenaline will be released. But let's just imagine if that snake comes home every night and you're in a constant state of fight and flight, hormones, elevated stress hormones constantly. That's a very different scenario. And some kids, they come home to that toxic stress every night after school, or they live in that toxic, stressful environment, which has very long-term effects. Just got this picture here with the trauma. You've got the medical trauma on the left, say. You might think of it, visiting, going to ER or having surgery, versus trauma that's not really seen. It's not very obvious, but trauma from, say, exposure to ACEs. And there's a very big difference between these two types of trauma, both in often recovery and long-term sequelae. So we can reduce the effects of ACEs and toxic stress, and I'll move on to the next slide to talk about that. 3 principles to improve outcomes for children and families. We're looking at supportive, responsive relationships. So even in our practice or your practice, even modeling empathy, actively listening, strengthening core life skills. That could be something to do with, parenting, referrals to parenting programs, workplace skill programs, having a chat with a GP, and reducing sources of stress. Do we ask about parental stress and coping? And what about other stresses? Do we ever inquire about other stresses such as finance, food security, domestic violence? And just talk a little bit about trauma-informed care. Trauma-informed care really acknowledges the needs to understand a patient's life experiences in order to deliver effective care. It has the potential to improve patient engagement, for patients to adhere to treatments, for health outcomes, and for staff wellness. It really has, so the implications really of this ACE study and learning about toxic stress and trauma-informed care, it has implications for us in practice, just to be aware, to understand, or maybe screen for a child's ACEs, or understand the experience of the child, particularly those kids that you are seeing in out-of-home care, and to realise that by using a trauma-informed practice, we can be more, what was that, sorry, Brooke? Holistic, yes, thank you, that's the word. We can be more holistic in providing care to our clients. And the 3 pillars of trauma-informed care really, if you can provide care which promotes actions to strengthen safety, they need to have a safe atmosphere or environment, connections with, you know, forming relationships and nurturing relationships, and also having help in managing their emotions in order to deal with the toxic stress that these kids have experienced. I'm going to actually hand over now. There'll be a period at the end for some questions and we'll share resources, but I'm going to hand over now to Brooke, who's going to talk about Holly is going to now talk about early intervention in child development.
Thank you, Brooke.
Thanks, Nicola. I just have one slide just to quickly talk about with you today, just regarding early intervention. So whether we're talking about child development concerns coming from that trauma or insecure attachment background, or indeed if we're talking about other causes such as neonatal events, birth trauma, genetic chromosomal abnormalities and metabolic disorders, acquired brain injury or neurodevelopmental disorders that has no known etiology, the principles around early intervention are essentially the same. So I've just put here a quote at the top that really for me sums up what we mean when we're talking about early intervention and why it's so important. So this quote came from an inquiry into the evidence around early intervention, and it comes from a detective superintendent from a violence reduction unit in the police force. It's actually from the UK. And so he's talking about having read all the evidence around early intervention. What he says is, if I had the choice between 1,000 extra health visitors, and I want you to put in there 1,000 extra trauma-informed practice nurses, child health nurses, trauma-informed GPs, frontline health clinicians that have the capacity to be able to respond in the early years. So put yourselves in there. If I had a choice between 1,000 extra of these and 1,000 extra police officers at the other end of the scale, I would choose 1,000 extra health visitors every time. And really what he's saying there is we have an opportunity to intervene early. That's not to say that we can't intervene later on, but it becomes much harder. It becomes much more costly, but it's also harder for the child because of what we've talked about around all that brain structure and attachment. And so what we're talking about with early intervention is the earlier that we raise issues and start to talk about issues with primary caregivers and start to make some of those referrals and follow up on some of those referrals, the better the life course trajectory is for that child in the longer term. Too often policies for the care of children in that social, particularly in the social, emotional and mental health spheres, they are based on the principle of waiting until matters go seriously wrong and then intervening with too little too late. So I'm just going to hand over to Brooke, who's our child health nurse, to talk a bit about some of those interventions.
Afternoon, everyone. So this afternoon, I'm just going to have a look at some of the tools that we can use with our clients in order to implement this early intervention. So one of the most common tools that you will have already come across when working with all our clients is actually their personal health record. So it's actually a useful guide to a child's health, growth and development and vaccination history across the years. So this guide also has within it a little book that kind of gives the parents some answers to some of the things that might arise in that first 12 months in particular. And it's a really good resource just to refer back to, I suppose, with some of their questions that they might have around their baby's development. Within this book, we also talk a little bit about the health checks and developmental assessments. So you'll notice that inside it does have the tabs, and we have health checks that are recommended at 0 to 4 weeks, 6 to 8 weeks, 4 months, 6 months, 12 months, 18 months, 2.5 to 3.5 years, and 4 to 5 years. So one of the most I suppose important things to know about this personal health record is that it actually travels with the child. So even our out of care children should have them, as they're usually the best source of information between the services. So it allows, everyone involved in that child's care to actually see what's been happening with the child and what appointments they have attended. So immunisations occur at all but one of those assessments. So immunisations need to be up to date for our parents to receive their parenting payments. So it's often the perfect opportunity to bring them into the clinic and to use the opportunity to assess them further and to make sure we're making every contact count. So bare ways should actually be conducted and be the norm for these developmental assessments up to and including the 18-month of age assessment. So this also allows for visual observation of the child. So in doing this, we can actually note all our observations. So you note any bruising, any scarring, any nutritional concerns for the child, or any general hygiene concerns that you may have. And of course, refer on if you do note some concerns that need addressing. We also can use this opportunity when we're doing the health assessments in order to observe the interactions between the parent or the caregiver and the child. So as Holly mentioned earlier, having a look at that attachment between them, that attunement, seeing if that child does, react positively or calm, when the caregiver is actually speaking to them or helping the nurse to do the undressing and redressing and that type of thing. Okay. So within the Red Book, there should also be at all the developmental assessment points, a PEDS developmental screening tool. So this was actually introduced in 2005 as Queensland's universal primary developmental screening tool. So it's included in that book from all the 6-month health assessment checks right up through to that 4 to 5 year check. So this questionnaire should be completed by the parental caregiver, and basically it's 10 questions, and if they do answer yes or a little to any of these questions, we should actually then look at identifying the areas of concern and the possible need for referral. So I understand back in 2015, 2016, the full training was actually rolled out within the PHN as well. So we may actually, a lot of our practice nurses and that out there possibly already have this training and can complete the evaluation themselves. Otherwise, you do have the option to refer on or into child health support systems in order to actually look at what do we do with this information for these mums that do answer yes or a little. Okay, so it does leave us with a little bit of a question, I suppose, as what if the parents have no concerns, but you as a clinician notice a concern? So that leads me to talk a little bit about the Red Flags guidelines. So the Red Flags Early Identification Guide is for professionals to use to help identify developmental concerns for children from birth to 5 years. So it offers some broad expectations of children aged 6 months to 5 years across 4 different domains. These domains are the social, emotional, communication, cognitive, fine motor, and self-care, and gross motor. So the guideline refers to what the child is doing, or not doing, I should say, rather than what the child is actually expected to do. So a lot of our, I suppose, education resources out there tell us what we should be expecting at a certain age, but the Red Flags guidelines actually identify those really concerning ones that if the child isn't doing this at this age, that is quite a concern. So a resource that does offer developmental expectations from birthright to 5 years is actually Mary Sheridan's book. So if you are interested in more looking at those broken down bits of what they should be doing at different ages, that's a fabulous resource. Whereas the Red Flags is more just looking at those particular things that if they're not doing, that we would then look at it as a concern. So the Children's Health Queensland recommend its use to assist in discussions with the parent caregivers about typical development and understanding the developmental expectations of their child. So it's particularly helpful when that parent or caregiver doesn't have any concerns about their development, and it allows you then to utilise the red flags document to kind of help address that you have concerns yourself, okay? It also, I suppose, one of the biggest things that we do also need to think about is we've got to think outside the box, okay? What affects a child's development? So environmental factors are huge, genetics, nutrition, physical activity, their community. So a lack of opportunity is often one of the most common reasons a child is not reaching milestones. So if we do notice that a child is coming up on these red flags guidelines, it's not all doom and gloom. It's about then talking and educating with the parents and figuring out how we can actually help these children to learn new things and to develop along a little bit further. So I'm just going to show you this next slide. So this is basically what the Red Flags Guidelines document looks like. So you can actually access that on the CHQ website, and it'd be a great idea if you wanted to. You can print it out, laminate it, pop it in your offices, and then that way, as I said, you can actually use it to help explain and educate with parents that may not notice any concerns with their child, that these are the expectations where they should be at, and if not, what can we do from here and how we can help them both as a dyad. Okay, so leading on from that, another tool that we often use within the child health is actually what we call the ages and stages questionnaires. So this in Queensland has been adopted as a secondary developmental screening tool. So we do the PEDS as a primary tool, and then this is our secondary tool if we notice concerns or the parents have concerns and we need to kind of nut it out a little bit more and figure out exactly what's happening for the child. So there is 21 questionnaires right from the ages of 2 months to 5 years in this particular set of screening tools. So we adjust up to the prematurity for 2 years because these ones are actually broken down quite specifically. So each questionnaire consists of 30 questions across 5 core developmental areas. So these areas are communication, gross motor, fine motor, problem solving, and personal social. So it's more comprehensive assessment of the child's development. Okay, so it's once again completed by the parent and then evaluated by a trained clinician. So I believe some of the training was rolled out to the PHN as well, but obviously all our child health centres Queensland-wide have also been trained in utilising the ASQ. So that is certainly a great place of referral in order to get an ASQ completed if you can't do it within your actual own practice. So the parent actually completes it, then we actually have a little look at what that means and what comes up on that questionnaire. And then the child can actually, we can then actually initiate, I suppose, areas of concern, look at appropriate referrals, and resources available. So there is activity sheets we can give parents in order to help them to enhance the development in the 5 areas or in the areas of concern. And then of course we provide ongoing monitoring and surveillance. So GPs and practice nurses can refer directly to child health for an ASQ, and parents can also self-refer, okay? So you may come across a completed ASQ as well in your practice. So in the instance that a paediatrician referral is actually recommended, as these need to be made by a GP. So if a parent was to present or a caregiver was to present, we completed an ASQ and we noted that there was quite a number of concerns across those domains. Sometimes we would actually refer back to the GP in order to refer on to paediatrician. So the screening tool, yeah.
The ASQ is actually on Health Pathways and it's in a number of different languages as well.
Yes, Yes, thank you for that. Yes. So yeah, and so from so the ASQ, from that, it can be useful for GPs as well to from that to actually look at referrals to the chronic disease management sort of plans and the enhanced primary care plans. And also access to private allied health in the interim as well, because you can actually sort of nut out whether it's speech issues or, you know, physio or what the child needs in that sense. Yeah, so that kind of leads us on a little bit, having a little look at referrals and partnerships. So in this sort of area, obviously, we are very based on Westmorton's programs and services, I suppose, available to us, because that's where we would refer out to. So a lot of the resources you can actually find on Westmorton's Health's website, but I would also encourage those from the Darling Downs area to jump on to that website as well and have a little look at all the different pathways available to you through that. And yeah, and so Holly's actually going to nut out this a little bit further for you and talk about all the different services and go from there. Thank you.
Thanks, Bruce. I suppose, Holly, you might touch on it, but we also have a number of PHN funded services for children and young people, especially with mental health issues, if you get onto our service now.
Yeah, that's right. And I'm just conscious of time as well, just in case there's any questions. But essentially, we talked about putting together a resource list. And the problem that we have is that when we're talking about interventions, we're looking across health, social, disability, education, cultural, community. And there's an awful lot of services out there, and they change constantly, as we all know, when we go to refer families. So what we thought we'd do is just very quickly touch on the key partnerships and the key referral gateways, if you like, that might be helpful. So, so just briefly, Brooks talked about child health, and I think key thing here is that if you're not sure, if a referral into child health, definitely detailing what it is you're concerned about. So thinking about, you know, what you're concerned about from a parenting perspective, or from, you know, if you're concerned around that attachment, the attachment side of things as well. If you can be detailed in your referral through to child health, they can also act as a bit of a gateway and then refer on to, for example, the early intervention parenting support team that we have here, specialist social workers who work around issues of attachment, behavioural issues. They work around issues like postnatal depression, and they offer something called Circle of Security, which is an evidence-based intervention around attachment needs. So Child Health can gateway into that service. They offer Triple P at different levels, and that's around supporting parents with managing behavioural difficulties. Obviously, they've got the drop-in clinics, they do the ASQ screening, and they can be that gateway. Paediatric nurse navigators is the other one, so I'm one of them, and I have, there is also a general paediatric nurse navigator who is coming on board very shortly. But we are more than happy to have case discussions with GPs and practice nurses, and we can provide consultation and liaison as well. You obviously can refer into navigation for that more complex, in-depth navigation piece of work if you've got a very complex situation in terms of either paediatric medical needs or from that disability behavioural perspective. But we also do what's called light touch navigation, where we might not need to get too involved, but just a short piece of work to help bring things together for a family and a child is all that's needed. You have the Child Development Service there. So if you have concerns across 2 or more functional domains, they are an assessment and diagnostic team, and they do offer that diagnostic clarification as well. The referral is by GP only for that service, and it comes through the actual paediatrician referral pathway that is then onwards referred to Child Development Service from there. I think a really key message for me to get across today as well is the FACT service, the Family and Child Connect service. You're probably already aware of it, but that is definitely a gateway referral. So if you have concerns and they're more around that social, the social disability, the cultural, the community, and you want some interventions around that, also around parenting, then a referral through to FACT being really quite detailed about what you're concerned about. They will then look at a multitude of other services to then connect that family into. So your intensive family support service, for example. I've popped on there the Ask Izzy website. That's actually quite good. If you pop onto the website there, Ask Izzy, you put in your postcode and it says what particular areas that you're looking for support in for your patient. So it covers things like mental health, it covers housing, finance, and all of those things. That's quite a good resource. Disability-wise, you have EACH, who are our childhood early intervention partners, and Carers Queensland. So 7 and up is Carers Queensland, and EACH is 0 to 6. And I've just popped in there the mental health supports there that are available, which Tanisha's touched on as well through the PHM. So that's essentially it. There's a list of, on the end there's just a list of references there of some of the things that we've talked about. But are there any questions, Tanisha, from anybody?
Margie, are there any questions in the chat box? I don't have access to the chat box.
We've just had one from April Turner. She just mentioned that Kambu are culturally safe and can respond with connection to culture. And she's also asked what the waits are like for any of these services.
Okay, so yeah, so definitely Kambu would definitely be on our list in terms of who we would refer to from that the Aboriginal Torres Strait Islander perspective. But in terms of wait lists, so for child health at the moment, I'll just ask Brooke, what are the wait lists?
We can see them dropping.
So I think, yeah, so.
We see them immediately. As for appointments, it's usually a week.
Okay, so Brooke was just saying that access via drop-in clinic, so obviously there's no wait lists for that. Or if you want to do a referral, usually they're contacted within a week. The early intervention parenting support service, I'm not sure what their wait times are like at the moment, but they're usually fairly prompt in terms of being able to respond to families. From a child development service perspective, it really depends on the clinic that the child is indicated for and the categorization. So, you know, for example, they have feeding clinic, they have the special care nursery drop-in clinic, and then they have the multidisciplinary assessment clinic. For nurse navigators, it depends on the triage of that referral. At this point in time, it's just me, but I'm just about to have a colleague come on board, which I'm very excited about. So generally speaking, we do respond in the nurse navigation, paediatric nurse navigation, within the first couple of weeks of having a referral.
Thanks,
Does that
Holly.
answer questions? Yeah. Any other questions?
No, no further questions. Thank you.
It's 1:30. I suppose I just wanted to add that we have resources on health pathways and as well. So I'm hoping that the practices are starting to use health pathways, because we do have a children in care health pathway. I don't want to take up any more of your time because we've reached 1:30. The session has been recorded. It's been an excellent session, incredibly informative. So I'd like to thank Holly, Brooke, and Nicola. The ACEs data is so important for us to be aware of in general practice, and really to increase our level of vigilance. And if I think about children in care, I'm sure just about every child you see that is in care would have at least 3 of these adverse events. So, you know, to be aware of that trauma-informed consultation as well. And YouThrive is another one of our PHN services for mental health. So that unlocks about 21 visits. So just to make everyone aware of that. So I'll end the webinar if there aren't any more questions, Margie.
No, no further questions. Thank you.
Okay. And I'd just like to thank everyone who's attended online. We really appreciate your time that you've given to us, and thank you to our presenters. It was excellent. Thank you for your time and your expertise in this area. Thanks,
Thank you,
everybody.
Tanisha.